very much. So because of the very fast pullback speed, OCT can reconstruct the very fine and very exact longitudinal reconstruction. Because of the IVAS pullback is very slow, so there is an overlap of the longitudinal image. So I think OCT is not able to detect the stent fracture in daily clinical practice. By contrast, OCT is very sensitive for the detection of the stent fracture in chronic phase. But the basic is the fluoroscopy.
Suppose the patient is having a spontaneous coronary dissection. So in that, in those cases, when you use OCT, you have to give a high volume, high pressure injections.
Yeah, that's right.
Does it make it worse?
Yeah, so there are some case report indicating that the OCT detected the ostium of the dissection and clarified the mechanism of the spontaneous coronary dissection. However, I think routine use of OCT for the suspected spontaneous coronary dissection should not be performed because of the possibility of, as I said, to use the worsening of the coronary dissection. And also, if the intima is very normal, sometimes OCT underdiagnose the development of spontaneous coronary dissection. So I think in clinical case, first IVAS may be better for the diagnosis of the SCAD.
Suppose you are not aware of the exact test what was used earlier. Suppose if the patient is coming for PCI follow, okay, you did the 3D OCT. So based upon the links and joints, connectors, so they say this is the pattern, this is like a Exine stent, this is like a Orceto stent or Promiscuous. So what is your personal experience with this one? Can we, based upon the OCT image, can we say this is the Grand stent like that?
You are
Some
right.
people report that actually this the diagnosis of the stent, even labeling can be done.
Yes. So one we have to think about the one possibility that if the stent is totally buried with neointima, it is impossible to detect the stent shape even with OCT. However, the neointima is very, in case with thin neointima, OCT can clearly reconstruct the shape of the stent strut, which can determine maker, manufacturer of the stent.
Suppose after procedure, like after you have achieved adequate main luminal area, main surface area, so suppose still malapposition is there. But once you achieve the adequate stent area, is it okay with it, or we have to oppose it fully?
Acute malapposition just after stent implantation is not the independent predictor for the development of future late stent thrombosis. However, if the patient has very significant malapposition after the stent implantation, if patient develop another coronary lesions after stent implantation, in such case, malapposed strut is the obstacle to the next procedure. So I think if OCT shows the significant malapposition more than 500 micrometer, it's better to use larger non-compliant balloon to decrease the degree of stent apposition.
Each study is saying a different criteria for like malapposition. Like a Clio PCA, they said 200 microns. Some studies said in 360 degrees, 360 degree is there, like 366 microns are there. Almost 100% will not heal. But if it is less than 360, almost 100% malappositions will heal. So what criteria you take? 500 microns?
Yes, so in my personal experience, malapposition more than 500 micrometer cannot be attached or covered by tissue in chronic phase. This is my personal impression.
Regarding under expansion area, like Illumini study, 3. They put a strict criteria, like a proximal of more than 90%, distal of more than 90%, compared with the distal landing zone, proximal landing zone. But even in that study, though they have put these for successful criteria more than 90%, but even in their study, they achieved only in 60% of the patients. But subsequently, they said at least 70% should be achieved to say there is no under expansion. What is the minimum area you see, sir, when you do the under expansion? But sometimes it is not possible to get the 90%.
That's
maybe
right.
because of the thickness, maybe because of the calcium. But Clio PCA clearly mentioned the distal and proximal mean lumen area should be more than 4.5 square mm. When it is less than that, those patients were having ulcer with more macerating. So, what is the criteria you consider?
Thank you very much. As you said, the minimum lumen area after stent implantation is the most significant predictor for the poor outcome in chronic phase. So, we have to improve the stent area and stent diameter as much as we can before finishing the procedure. And recent expert consensus document from EAPCI, European Society of PCI, have shown that the relative stent stenosis less than 80% is a predictor of worse outcome. So they recommend to improve the relative stent minimum area more than 80%. This is, I think, the most well-known criteria for the stent expansion. And also, the minimum stent area is itself is important. However, it's dependent on the where the stent is implanted. So if the stent is implanted in the proximal part of the coronary artery, the minimum stent area should be larger than the stent implanted in the distal part. Makes sense? So I think important thing is the relative minimum stent area more than 80%.
How do you foresee the future development of OCT? Like the one main disadvantage, very high resolution, but penetration is only 1 to 2 millimeters. So do you see some more like a more penetration like that?
So, but as I said to you, the most important thing for the prediction of patient prognosis is the lumen area. So important thing is in clinical settings, important thing is the lumen area. So OCT is very, very sensitive for the measurement of lumen area. So it's better than IVUS. So this is the first priority of the IVUS. But theoretically,